Hi, everybody. Just trying to get a bit of a move on with our fractures. Uh, this is going to be our last radiology one for a little while. I'll be doing some other emergency department topics and cases and, um, sorry, a few ECGs in the next coming weeks. Um, Anyway, so we had covered the upper arm previously, and we had gone through about three or four presentations, and then we finally get down to the wrist. So this is a bit of an older presentation that I used to do with my students and interns and ComServes before. So it was done in an older format. So just the bit at the bottom is cropped out. So I hope that won't be a major problem and that you can still see everything. All right. And it's one of these that I really enjoy. And yeah, let's get into it. So, what should we know about wrist fractures? So, they are some of the most common fractures that we see, and also some of the most easily missed because some of the bones are extremely tiny. We have a tendency to want to look at fractures and just pick them out, or look at x rays and just pick out fractures without actually assessing the entire x ray. And yeah, it can lead to significant disability if untreated. Because if you have an unstable wrist, essentially you have an unstable hand. Yeah, and so especially if the wrist is not stabilized. I mean, you end up with a person who can't use that hand, and especially if it's somebody who does physical labor. I mean, this can affect their entire life. So it is quite important to make sure that we know what's going on. And once you know what to look for, it's actually quite easy. So we'll try and go through it. So let's look at a normal wrist. So the first thing I always ask people is, can you name all the bones in a normal wrist? And most of the time, I just get blank stares when I do this. So the question is, can you name the bone? So if you're not sure, pause the video now and try and see if you can name all of them. And if you can't, we'll go through them. All right. So you've got the scaphoid here, you've got the lunate, you've got the triquetral, and then you've got the piriformis. Okay. So essentially the three big ones, and then you've got a little piriformis bone that's over there. The trapezium, the trapezoid, the capitate, and the hamate. All right. So it's just those few bones. That's it. And I mean, I've done anatomy now maybe 25 years ago. It still sits in my head, and I would expect you guys to also know how to do that. And they've got your radius and your ulna. So there's a few things that we have to make note of. First of all, the bones have a natural arc or arch to them, and so you have the proximal arch over here, which is proximal to all of the metatarsals, and then you have the two. Arches, the more distal arches that are, or let's say the intermediate and the distal. Now, the thing is, when you're looking at a normal wrist, these arches should all be generally in alignment. Now, of course, it's a generalized thing, but of course, if you have a capitate that's sitting up there, or you have a scaphoid that's out there, that's the first thing that you would notice when you look at it. And if you look at the angle from the medial styloid, or let's say the medial end of the radius to the lateral end, then you should be seeing a slope that's kind of like this. All right. Now, these are things that when you do orthopedics, you actually have to measure them uh, quite precisely. But as an emergency room doctor, you just eyeball these things and just kind of make sure. And the last thing that you have to make sure of is also the distance between the bones. So they can't be a very large distance between them. And we'll get into that a little bit later and have a look at an example of that. All right, so let's have a look and see. So this is something in the emergency room that we talk about, which is the zone of vulnerability. All right, so these are where your fractures most commonly occur. It doesn't mean fractures only occur here. It means this is the most common area for them to occur. All right, so most injuries occur because of FOOSH, what we, basically use the acronym FOOSH, which means fall on outstretched hand. So this is an easy way just to categorize the injury. All right. So what happens is that once you come on the radial side and then progress to the ulnar side, as you're on this end, these fractures are more common but less severe. So in other words, you expect to see, let's divide it into half. So in this half, these fractures are much more common. So a radial, what you might call a radial styloid fracture is very common, but is not very severe. A mid-capitate body is also relatively common but not as severe. And then if you had to compare a scaphoid to a triquetral, for example, so the triquetral would be less common and more severe, but it would be, the capitate would be more common than the triquetral and also less severe. So that's how you look at it. So when you start from here, you're talking about more common, less severe. And as you progress along here, they get less common, but more severe. And when we say more severe, we mean more difficult to treat and more complications. That's basically it. All right. So if we had to look at this, so like I say, a radial ulnar, a radial styloid is common but not severe. An ulnar styloid fracture is less common but more severe. It's more difficult to stabilize. And a scaphoid waist fracture is more common than a hamate fracture, but the hamate fracture is more severe. Okay, so that's how we look at it. All right. So also dislocations and things like that, dislocation fractures as well. So it's just something to consider. So very often, if you have a patient with something on this side of the spectrum, it means that they can wait. But as you go a little bit more, then even if you're not sure what to do with it, at least you know you should refer. Okay. Now, this doesn't mean that the others don't get fractured. This is just the most common area for them to get fractured. The reason being that the forces that are passed through an outstretched hand generally pass through that area. Okay. So let's try some fractures. Now, what I would do is I would ask you normally just to take a few minutes, pause this here, and try and see if you can identify the fracture. So let's have a look. So we're basically looking at radial fractures, all right? So what we have here is a radial fracture that is posteriorly displaced. Here we have a radial fracture that's anteriorly displaced. And here we have a radioulnar fracture that is posteriorly displaced as well. Okay, so we're going to learn the names of these three. So the first one is a posteriorly displaced radius, right? So this is a Colles fracture, right? So that's something you should know, because Colles type fractures are some of the most common fractures that you'll see of the wrist. Okay, very common in the elderly, very common after falls. Then the one where it's anteriorly displaced. Now, this is a Smith's fracture, which is also relatively common. It's just that the direction of force is exactly opposite to a Colles fracture. Okay. And then here we have what we call a Barton's fracture. So what's happening is it's not just a fracture, it's also a subluxation of the carpal bones and the radius. Right? So that's why that little arrow over there. There's something called a volar type, and then you get a palmar type as well. But that's not important. In fact, Barton's fractures are not as common, and they're generally seen after very severe falls or quite significant trauma. Okay, so here we're going to have, let's try and name this fracture. So here we have a fracture that's slightly, well, you've got to decide which way is it going? Is it going anteriorly or posteriorly? Now, when you look at this, remember, this is completely opposite to the other one that we saw. We had watched everything on the right hand. This is the left hand. So when you look at the left hand, it's actually posteriorly displaced. So that's a Colles fracture. And then when you look at this one, again, it's on the opposite hand. Here you have it anteriorly displaced. It's a because there's no subluxation here, so it's a Smith's fracture. Okay, so let's have a look at this. So here we have a radial styloid fracture. Is it common? Yes. Is it severe? No. Does it still need treatment? Of course. Okay, so that's what you need to think about. Okay, let's try another one. So now from the opposite side, we have an ulnar styloid fracture. So is it common? No. Is it severe? Yes. When we say severe, remember we're talking about in terms of repair, okay, as well as stability. Okay. So now we're going to look specifically at the carpal bones. All right. So remember, we have scaphoid, lunate, triquetral. Now, the first thing that you'll notice if you look at the arch, you can see the arch is displaced. It doesn't look like a normal arch. All right. Now, that can also be because of hand position, but even if you're not going to consider hand position, you can still see that it doesn't look 100% like what it should. We can notice an easy fracture over here, and we can also notice displacement of the bones. All right. So the distance between the carpal bones is increased. But if you really had to look at it, this is a scaphoid waist fracture. All right. How severe it is? It's not that severe, because we're still at this end of the spectrum. Remember, now this is the opposite way around as compared to the picture that we saw, which was of the right hand. This is of the left hand. So it goes the other way around. And what is the danger of this fracture is what you call it, avascular necrosis. The reason being that this falls into a watershed area. So you've got blood flow that's coming from here, and then basically winding back. So once you get a fracture there, there's nothing else supplying blood to this piece of the bone. So it's quite common to have avascular necrosis. So it's very important to make sure that the scaphoid is actually looked at properly. Now, most of the time, if it's a very minor fracture or a hairline, or not as obvious as this, we'd ask for scaphoid views as well, right? And if you're placing in the POP, then you've got to place the patient in the holding the cup position. And if you're not sure what that is, go and check up with your orthopedic guys. Will show you exactly how it is. Now, let's have another look and see. Can we see a fracture anyway? All right. So we can. There is a fracture here. All right. So the fracture is quite subtle. You can't see it all that easily unless you really look for it. Now, one of the other things that you can ask, or you can check out, is check for pain on the anatomical snuff box. So you press directly on the anatomical snuff box. That normally gives you pain in a scaphoid fracture. And if you try and move the thumb around at the same time, it's very painful. So those are clinical indicators of a scaphoid fracture. All right. So if you're not really sure, like I say, let's say you have a patient, you're not really sure, maybe you don't have access or the orthopedics are not prepared to take at a higher center, put the patient in a POP, re-X-ray in 10 to 14 days, but know the type of POP. So, right, so it's a POP of holding a cup. Right. So your patient, even if you can't remember it exactly, your patient should be in the position where they could hold a cup afterwards. Okay. So let's find some fractures. So if I were you, I would just take a few minutes and just quietly look at all of these and okay, so take a few minutes and just have a look through all of these and see where you can see the fractures. Okay. Now, if you've done that and you've already rejoined the video, then you should have found the first one at least. So again, be prepared to name the bones and look for abnormalities. So the first thing that you'll notice, even if you don't notice the fracture, but you'll notice the wide displacement of the bones over here. And if you look at the arches, those ones look okay, but this one here, just not 100%. Now, when you come to it, then you've got the small fracture here on the head of the scaphoid. Okay, that's going on. If you come to this one, you can see another scaphoid fracture that's just running through there. I'm afraid to annotate because right at the top it may not show properly. And if we have a look at this one, you can see there's a fracture at the base of this metacarpal. And if you look closely, you can even see the fracture in the scaphoid that's going on over there. I think it is if you look quite closely. So these are the three fractures that you would get. Okay, yeah, there we go. So I had actually pointed it out. Sorry. Okay, so let's have one more. Now, with this one here, I really would suggest pause the video for about 5 minutes. Have a look at all of these x-rays quite closely. Now, each one has a fracture. And this one here is quite fun when we do it live. And we have done it live before. And it's a lot of fun for me because I get to see people sweat. And I've also seen some people who are natural orthopedics who can just pick out the fractures immediately and know that something's going on. So have a look. It's just for fun. These are not common things. You won't see them all the time. And we'll talk about it afterwards. Okay, so let's have a pause now. Okay, so if you've paused and you've come back, then you obviously realize that I'm quite sadistic in giving you all of these because they're quite difficult fractures, actually, you know. So what you're going to do is you're slowly but surely going to go through each of them because when you see them, then you'll be like, oh, how did I not pick it out, you know? So let's go on to them and just have a look and see. So here we have a triquetral fracture. So you can see the slight hairline that's going through. Here you can see a hamate fracture. Now, hamate fractures are also commonly associated with fractures of the third, fourth, and fifth metacarpal as well. So always have a look at those too. And these can be quite difficult. So you might sometimes see a very heavy overlap. And what may look like artifacts, especially if there's a hamate fracture, may actually be fractures of the third, fourth, and fifth. And here we see a scaphoid fracture of the entire head. All right, and you can see it's quite osteoporotic bone on this one and osteoporotic bone on this one. This is why these fractures tend to occur in slightly elder patients. This one here is more likely a fight induced, so a hit where the outer three fingers actually struck the opponent, let's put it that way, and caused the fractures as well. So you can see this fracture is completely gone into. So the question is, which is the most severe? Well, just going according to the zone of vulnerability, this would probably be regarded as the most severe. But in reality, the hamate fracture is quite bad because repair here is not easy, and gaining stability after that is not easy as well. The scaphoid is actually the easiest. So what would make you worry in these patients is the fact that you'd have a very swollen hand. inability to hold, inability to place pressure on the hand, severe tenderness, decreased range of motion. You might even get bone crepitus, like for example, in this one, because it's a complete fracture, and in this one, where there's a complete fracture, you might actually feel bone crepitus underneath. So in these ones, if you are clinically suspicious, remember you treat patients, not x-rays. If the patient has, and these do cause severe swelling, patient needs review by an orthopedic surgeon or an orthopedic MO, somebody who's got more experience at leading these, or at least a radiologist should have a look at them at least as well. All right, so please remember to do that, because these can be very subtle. That's the whole point of showing you these. They may not be common, but they do occur. Okay, and then of course, if you look through what we were talking about earlier with the arches and things like that, in this one in particular, and even here, you can see the arches are all just a bit messed up, but specifically in this one, it looks quite bad. Okay. Right, so let's look at some dislocations. Now, often when we get the wrist, we often look at the lateral side. And I've seen many young doctors look at the lateral side and just kind of go, And when you ask them, what are you looking for? They also just say, because they're not really sure what they're looking for. So what we're looking for when we look at this lateral side is we're actually looking for dislocations of the wrist, all right? So when you look at it from the lateral side, what you're seeing is the capitate, all right? You see the lunate and you see the top of the radius. Now, the way that a normal wrist should be, you've got to imagine the capitate is equal to an apple, kind of looks like an apple. The lunate looks like a cup, and the top of the radius looks like a saucer. So the apple should be in the cup, which should be in the saucer. The apple mustn't fall out of the cup. The cup mustn't fall out of the saucer. The cup mustn't be away from the apple or the saucer, so on and so forth. All right. So the apple, capitate, sits in the cup that sits in the saucer. All right. So that's how we look at it. Now, that's a normal alignment as well. But this one here is something that I would suggest you pay attention to. If you can remember this, everything else becomes quite easy when it comes to dislocations. Remember, if you can name dislocations, if you can name particular fractures, very good. That's excellent. But all that will happen is the orthopedic will give you a pat on the back. At the end of the day, you want the patient to get the right amount of help. So let's have a look at this image and compare it to the previous image. So let's look for the apple. So here's the apple. You can see the capitate. And here's the saucer. So what's missing is the cup. Where is the cup? There's the cup over there. So we said the cup is the lunate. So what do you think this dislocation is called? If the lunate is out of place. It's a lunate dislocation. Right? Makes sense? The lunate is the one that's come out of place. So the cup or the lunate is displaced from the radius. All right. So the capitate generally goes posterior in these cases because it jumps out that way. But it's more commonly posterior. Let's have a look at this one and see. So what do we have? Here we have the apple. What's it missing? It's missing the cup. Right. So the cup is there, and where's the saucer? The saucer is there. So the cup is in the saucer. It's the apple that's fallen out of the cup, if I can put it that way. So it's not a lunate dislocation because the lunate is still in its place. So it's you could say capitate dislocation. That's not a problem. But the technical term is perilunate. Right? So perilunate. So the apple has dislocated from the cup, the lunate, right? But the lunate is still attached to the saucer. I hope that makes sense. And let's have a look here. So here we have the apple. The apple is not in the cup. Here we see the cup here. And is the cup in the saucer? Cup is not in the saucer. So in other words, all three elements are no longer attached to one another. Okay. So what is this called? This is a mid-carpal dislocation. Mid-carpals are when both the capitate and lunate are displaced. If you can remember that, which one is lunate, which one is perilunate, very good. Excellent. I'm happy for you. But if you can't, and if you can just remember the apple should be in the cup, should be in the saucer. And if the apple is not in the cup, it's a problem. If the cup is not in the saucer, it's a problem. Or any combination of that, like what we just saw. All right. So what is the problem with this? The problem is that if you don't pick it up, this is an unstable wrist. There's not a single fracture here. But if you leave this patient alone, they're going to have an unstable hand. They'll never not be able to use that hand. The longer you leave this dislocation, the harder they are to repair. Okay. So this is one that we need to see. So very often you would have gone through all of this process and your patient is still in a lot of pain. One of the other common injuries that we get is a scapholunate dissociation. All right. It's called the Terry Thomas sign. There was an actor named Terry Thomas who had a very large gap between his two front teeth. So it's sometimes called the Terry Thomas deformity. Okay, so it's a very wide spacing. They'd almost say about 2 millimeters, but it's one of those things where if you have it, orthopedics needs to judge and they need to see. It's very easy to miss, and it is an unstable wrist. So these can happen in any of these bones, but this is the more common one, right? So severe pain on movement in the absence of a fracture should just make you go back and check for this. And I've missed this a few times. I'll be honest. When I say missed it, what I mean is I put the X-ray up. I haven't seen it. I've gone through each and everything. It's like, no man, there's still something wrong. And then you go back and you think, okay, what about this? And that's when you find it. Okay, and then your patient will thank you later on. So this is just a little joke to finish off. Let me just okay. So, and I think that is a great truth over there, especially if you've had diarrhea, then you know. So, like I say, we'll be carrying on with X-rays in a little while, in a few weeks again. I've just got to build up the courage to hit the book that's got all of these images. I've prepared so many presentations, but I just haven't got the chance to get back to that book again. So I'm trying to do it according to a syllabus, and just haven't had the opportunity. But if anybody has any sort of questions or has anything that they want to know, you're more than welcome to let me know. And I hope you'll enjoyed it. And yeah, I hope you learned something from it as well. Right? So it's very much from an emergency department point of view. It's not from an orthopedic point of view. Because remember, with us in radiology and fractures, we're just trying to identify and get the patient to the right person. We're not actually worried about further management and stabilization and that, unless you're working in a full trauma center where you're setting up your own POPs and things like that, then you've got to know those techniques as well. For those of us who are working in segmented emergency departments rather than trauma centers, we generally don't do the POPs and stabilizations. But for the majority of them, the stabilizations are quite easy. It's the type of thing where you can even Google and they'll give you direct instructions, because there's so many different ways of placing the POPs and stabilizing, and of course how you reduce and things like that. But our main purpose here was identification. If you can't identify, you can't move further. So I hope you'll enjoy the identification part of it, and keep well, everybody. Bye.